Good evening. I see that everybody is very excited about the lecture tonight. I'm sure that that's the only thing that you're talking about now. Good evening again. Thank you for coming out tonight. My name is Juan Belmo, and I have the privilege of being the Dean of the Byrdine F. Lewis College of Nursing and Health Professions at Georgia State University. Welcome to our college's 21st Annual J. Rhodes Haverty Lecture. The Haverty Lecture is our signature annual lecture that was established to honor Dr. J. Rhodes Haverty, our founding dean of what was initially called the School of Allied Health. Dr. Haverty led the school and the subsequent College of Health Sciences for over 20 years. Every year, the Haverty Lecture features nationally recognized experts in healthcare, such as the former medical director of the American Cancer Society, Dr. Aldous Barley, former Surgeon General David Satcher, and Dr. Jennifer Arnold, the medical director of Simulation Center at the Johns Hopkins All Children's Hospital. So a big thank you to our Faculty Advisory Committee who chooses the speakers each year. If the Faculty Advisor members, committee members are present tonight, would you raise your hand to be acknowledged? Thank you. We're very pleased to have all of you with us tonight, and I would like to welcome also several members of our college's advisory board members who are here with us tonight. Susan Leard, Jim Forbes, Kevin Nichols. Did I miss anybody else? Kevin, over there. Thank you. You always provide us with advice and engage with our students and faculty and staff and help us in so many ways, so thank you. And also like to thank our provost, Dr. Nicole Parsons-Pollard, for being with us tonight. She's sitting in the front. You will hear from her in just a minute. But before I turn the podium over to our provost, I want to take this opportunity to highlight a few of our recent successes of the college. Our School of Nursing's BSN program this year has jumped 59 spots in the U.S. News and World Report ranking to number 74 in the nation and number 1 as a public program in the state of Georgia. Also, the Doctor of Physical Therapy program moved up from number 71 to number 58. And the Occupational Therapy Doctorate program moved up from number 108 to number 65 this year. All great news for our college, which just rose from the number 5th to the 3rd largest college at the Georgia State main campus in terms of enrollment. So congratulations to all. Now I would like to introduce Dr. Nicole Parsons-Pollard, who will offer the university welcome. Dr. Parsons-Pollard served as the university chief academic officer. Her portfolio includes development of university academic programs and international initiative, and oversight of institution effectiveness and strategic planning. As provost, she has reorganized her division to better support academic strategic planning and online education. She has created a variety of faculty development programs to help retain and engage one of the university's most precious resources, the faculty. Her academic field of interest is in criminal justice, with her research centered on juvenile justice and the disproportionate minority contact by the criminal justice system. So please, join me in welcoming Dr. Parsons-Pollard.
Thank you, Dean Moe. Thank you for your leadership and for the kind introduction. And I want to say congratulations to all of the faculty and staff and the students in the college that made it possible for us to have those types of recognitions that he just shared with you. And so I appreciate all of the hard work that has gone into that. I'd like to say good evening, and on behalf of President Blake and the administration of Georgia State, it is an honor to welcome you to the 21st Annual J. Rhodes Haverty Lecture. I'd like to also thank the talented faculty and staff and students of the Lewis College and health professions for putting this important event together. And I am extremely excited each year when I come here to see more and more students sitting here in this venue. I believe that we have some other deans and other university leadership here. If you don't mind, if you could stand so that we can acknowledge you, please, I would appreciate it. Thank you. It is an honor to be here tonight as we celebrate this important tradition that began in 2003. Named in honor of the college's founding dean, J. Rhodes Haverty, this lecture series embodies Georgia State University's commitment to addressing contemporary health issues and fostering meaningful discussions that resonate across our communities. Each year, we are privileged to welcome a renowned expert who shares their insights on vital topics that appeal to a diverse audience, including our dedicated students, alumni, and community leaders. And I know that we are in for another engaging talk tonight with Dr. Kenneth Thorpe, the Robert W. Woodruff Professor in the Rollins School of Public Health of Emory University. I'd like to thank Dr. Thorpe for spending time with us this evening, and I appreciate having you here. Thank you. The conversations that arise from these lectures not only enrich our understanding, but it also inspires us to take action in ever-evolving landscape of healthcare. Thank you all who do this work every single day to make our world healthier and a healthier and safer place to be. And together, let's embrace the knowledge and inspiration of tonight's promises that will come from our talk this evening. I look forward to hearing Dr. Thorpe. I look forward to your conversation, your questions afterwards. And I am now going to bring up Professor Stephanie Scales so that she can have an opportunity to introduce our speaker. So I'd like to bring her up now. Thank you, Stephanie.
Thank you, Dr. Parsons-Pollard. Good evening, everyone. I'm Stephanie Scales. I'm a professor of health informatics here at the Lewis College, and I chair the Lewis College Faculty Advisory Committee. We oversee tonight's events, including the selection of our speaker. And I'd like to thank our committee members and the rest of the faculty for their contributions. I would also like to thank our donors to the Haverty Lecture. They're listed in your program. We're truly appreciative and grateful to them for their generous support over the years and hope that many of you will join us financially so that we may continue this outstanding lecture series. Now I have the great pleasure to introduce our featured speaker tonight, Dr. Kenneth Thorpe. Dr. Thorpe is the Robert W. Woodruff Professor in the Rollins School of Public Health of Emory University and chair of the Partnership to Fight Chronic Disease, a coalition of more than 120 organizations seeking to raise awareness of the negative impact of chronic disease on the nation's economy. He is also chair of the board of the Better Medicare Alliance, an organization focusing on the Medicare Advantage program. In addition to holding a number of faculty positions during his career, Dr. Thorpe was Deputy Assistant Secretary for Health Policy in the U.S. Department of Health and Human Services from 1993 to 1995. In this role, he coordinated all financial estimates and program impacts of President Clinton's healthcare reform proposals for the White House. Dr. Thorpe has testified before numerous committees in the U.S. Senate and House on many aspects of healthcare reform, including disease prevention, wellness, and coordination of care. He also appeared on NBC News, ABC World News Tonight, CNN, Fox Business Channel, and NewsHour. Please welcome to the stage Dr. Kenneth Thorpe.
Well, thanks for that overly kind introduction. Thanks for inviting me. I'm just right down the street, so that makes it handy. I appreciate the fact that the faculty got together and came up with a selection. I'm humbled and honored to be here. So I look forward to going through this presentation. I'm going to cover a lot of ground. And so hopefully I won't go too fast, but I really wanted to touch on some of the major issues that we're facing in healthcare reform on the cost side, the health insurance coverage side, and on the quality of care side. So as you're going to see, there's a whole host of issues that are going to be important in the next 4 to 10 years as we think about an election and we think about a new administration perhaps coming in. So the issues. I'm going to start with the costs of healthcare. And one of the underappreciated aspects of what's driving the growth in healthcare spending up is the fact that we have this epidemic in both obesity and overweight. Today, about 70% of the population is either overweight or obese. About 42% are obese. It's gone up from about 30% in the early 2000s. Some of the work I've done shows some of the implications of that, because we know with the growth in the prevalence of obesity, we have a rise in the prevalence of chronic healthcare conditions: diabetes, hypertension, lipids, COPD, asthma. You can go down the board. And I think what's striking about it is the increase in the number of people with multiple chronic conditions. So we're increasingly treating a more complicated set of patients. We're looking at a patient that's a hypertensive diabetic with elevated lipids, is depressed, has COPD, maybe has heart failure, all of whom need a different set of medical interventions and personnel to work with them. But more importantly, as I'm going to come to, that patient really needs to have a care coordination plan, because these are very diverse chronic conditions that need to be addressed, focusing on the whole person. The other issue that we're seeing, and we see this here in Atlanta, that there's been an increased consolidation of provider market power. So you need to look no further than my place at Emory and Piedmont and Northside. And, you're seeing what's going on with these academic medical centers that are not only consolidating in Atlanta, but are really looking at it from a regional strategy in terms of how they want to consolidate. That obviously potentially raises some issues on the cost side. We've seen a lot of attention recently paid to these new GLP-1 medications. Just in 2023, Novo Nordisk got about $18 billion in revenue from Ozempic. That's double from the year before. So that's an issue that is facing employers, health plans, Medicare, among others. The policy challenge that I find is that we kind of have an imbalance here in terms of where we're focusing most of our attention on and what I think the real need is to reduce the level in growth and spending. To me, taking on healthcare reform by silos of care, looking at just prescription drugs or other individual providers, hospitals, and so on, really kind of misses the point, because the real focus should be on how do we reduce the per capita level of spending. We really need a much more holistic view of this issue, because it's complicated. There are huge interactions between all those different sectors of healthcare services, and to date we really haven't had a comprehensive focus on the healthcare reform side that really looks at total per capita spending. Another underappreciated thing about why the United States spends so much more on healthcare, yeah, the prices are higher than they are in Europe, but the underlying chronic disease burden is much higher as well. So if you just look at the prevalence of adults with multiple chronic conditions, about 30% in the US, and if you look at some of the less expensive European countries like France, the Netherlands, they're in the low single digits. So the chronic disease burden, very disproportionately high here in the US. So what have we done? Well, we just came through a couple-year discussion and big piece of legislation focusing on prescription drugs. And just to take a step back, you may ask, why the focus on prescription drugs? If you look at the growth in spending over the last decade, 30% of the growth in spending is linked to hospitals, 20% of the growth in spending is linked to physician and clinic services, and less than 10% of the growth in spending is linked to prescription drugs. Yet all the focus has been solely on prescription drugs. And I can tell you one of the reasons why is if you look at the benefit design of health insurance, whether it's in private health insurance or in Medicare, the drug issue resolutes more with patients because the cost-sharing obligations are much higher. So what people have to pay out of pocket for prescription drugs is much higher than what they had to pay out of pocket for hospital care or physician services. So it's an area that resonates with people because they feel it at the pharmacy counter when they fill their prescriptions. So the Inflation Reduction Act was sold as a mechanism to get the high cost of prices of medications down. We'll come back to that in a second. To me, from a patient standpoint, the most important aspect of the Inflation Reduction Act was the $35 a month cap on insulin for seniors. And next year, 2025, there will be a $2,000 out-of-pocket cap annually for seniors on prescription drugs. So for many seniors that are dealing with very high-cost drugs, this is a really important aspect of the legislation. The way it was written is that CMS, quote-unquote, negotiates drug prices, and it started out with 10 drugs. The negotiations have been ongoing. The actual sort of limitations, what they call the maximum fair price on these drugs, will come into play in 2026. As a result of the legislation, the quote-unquote negotiations over the next decade is manufacturer revenues, the drug companies, are going to get $240 billion less in revenue. The flip side is that Medicare is going to save $240 billion in spending. Let's just go back to this point about drug prices. They picked 10 prices, or 10 drugs to start with. And it was interesting, the criteria, I don't know what I did here. The criteria for the drugs were not on the highest price drugs. So we've seen that there's a lot of high-priced drugs in the marketplace. That's not where the focus is. The focus was looking at the 10 drugs where Medicare spent the most money. Now, a lot of those drugs, their underlying prices really aren't that high, but Medicare spends a lot of money on it. So the real issue from a patient standpoint is that the biggest impacts are going to be on these out-of-pocket caps. Just the way the Medicare program works, seniors pay 25% coinsurance on drugs, and with the $2,000 out-of-pocket cap, any drug that costs more than $8,000 that is negotiated down doesn't have any impact on patients because they've already hit the $2,000 out-of-pocket cap. So you take some of these heavily advertised drugs that cost $50,000, $60,000, $40,000, negotiate them down by 20%, that's great for Medicare. They save all that money, has no impact on patients because they've already hit their out-of-pocket cap. The biggest concern that people have on the negative side of this piece of legislation is innovation. Obviously, the United States is the leader globally in innovative new drugs and medications. We know the cost of developing a drug through the three stages that it has to go through could be easily $18 billion to develop a drug. For most of these companies, you may have one drug that comes out over a decade. You may have 20 in pipeline, the other 19 never make it to market. So it's an expensive investment for sure. With that reduction in revenue coming into the manufacturing sector, but the good news is Medicare saved money. There's a wide variety of estimates on investment in drug development. Since the revenue stream is down, the expected return on investment down. There is concern, particularly in the private equity sector, which you've already seen, that private equity investments in pills is going to decline. It already has. The Congressional Budget Office, who's redoing these estimates, estimated it to have a fairly minor impact on innovation. The University of Chicago estimated that as many as 342 fewer drugs will be on the market over the next 20 years as a result of this piece of legislation. So it's a messaging issue in part for the White House that wants to do the cancer moonshot, which requires big investments in new treatments at a time when we're just sort of starting along this road. It's 10 drugs in 2026, then there's going to be another 15, another 25, and so on. So this keeps multiplying over time. So there is some concern on what impact this has on innovation. Well, what other approaches are out there? We did, take a silo-based approach on the drugs, and patients are going to win on this. This is good news. To the extent that patients pay less out of pocket for drugs, we know they're going to be more adherent. They're going to fill and refill their prescriptions. And as we know, medication management for these chronically ill patients that I talked about, along with really good primary care, is the really key essential aspects to keeping those patients as healthy as possible. So lower out-of-pocket spending will increase medication adherence and hopefully reduce heart attacks that happen because of uncontrolled blood pressure, strokes, uncontrolled blood sugar levels. These should all result in fewer ER visits, fewer ambulance rides, fewer visits to the hospital, and so on. So that's a good part of the legislation, which is why I focus on that aspect of it. But there are other approaches that are in play here that to me are more holistic, more comprehensive as a means for getting to value in healthcare. One is to continue the migration away from fee-for-service reimbursement. We know that fee-for-service reimbursement really promotes silo-based care. It promotes increased volume of care. And it really doesn't focus on whole person care per se. CMS has now for some time really trying to transition the Medicare program as expeditiously as possible into what's called value-based care, that you pay more for clinically based, evidence-based services to encourage their use. You pay less for services that really don't have anything but marginal clinical value, and so on. It relates to patients, too. In the Medicare program, there's a uniform co-payment for physician services and for prescription drugs. And this value-based approach would say, well, for those medications that we really want to encourage patients to use for diabetes and CHF and COPD and hypertension and lipids, why should there be any cost sharing at all? There's really no point to having a financial burden in front of a patient where the physician says, I clinically want to make sure that you're on this blood sugar medication, and I want to make sure that you're routinely taking it. So the value-based approach says maybe this 1960s version of health benefit design, which is a uniform cost sharing across all services, doesn't make a lot of sense. Other approaches that we've seen, and one of these just really came out of COVID, which are innovations in technology. So one of the things that I've seen to be most impressive is the real technological innovation in remote patient monitoring. There are RPM devices now that in one wrist, one patch, you can monitor up to 15 or 16 vitals. You can set up risk stratification approaches for patients. You set individual parameters for each of those vitals. And for patients that move outside of those parameters for a certain time period, that's when you deploy resources. As I'll come to in a minute, the other thing that's exciting about it is that the manpower needed to put this together is much less intensive than what we currently see in hospitals and what we see in home health care, because you can have essentially one nurse practitioner monitoring literally thousands and thousands of patients at the same time in the hospital, at home. It's obviously created this incentive for the hospital at home movement, where you can release patients earlier because you know that you can now track them clinically at home because you've got the technology to do it. So I think that's an exciting area where there's a lot of public policy going on right now about extending the reimbursement for telemedicine past the next couple of years. It was temporary. It came under the Emergency Use Authorization Authority. So it was temporary, but there's a lot of bipartisan interest, one of the few areas in healthcare where we actually have bipartisan interest to do something, to extend this. The role of AI to be seen. I think that's going to be an interesting area in terms of innovations to look at, automation, and so on. The next piece, it's up in Washington, though. They'll probably extend the telehealth provisions. They'll probably, depending on the Congress, one of the things the Inflation Reduction Act did was increase the amount of federal subsidies that go to individuals to buy health insurance through the exchanges. So we've had a big reduction that I'll show you in a minute in uninsured as a result of that. Those expire in 2025. So that'll be on the congressional agenda, perhaps this year, but certainly it's going to have to be on next year. And depending on how this election turns out, they'll either be extended or they won't. What will be on the docket next year, and again, this is an area that does have bipartisan reform. It's starting in the Senate Finance Committee with Senator Wyden and Crapo and others, looking at the pharmacy benefit management system, the PBMs. So the Congress reacted to the high price of drugs by simply coming in and capping payments. But what I was hoping to see was a broader policy discussion about what underlies those drug increases, the price increases. What's going on? What are the factors associated with it? And I'm going to give you an example. Give you an example of insulin. I try to make this simple. There's 3 lines here. Simple for me. You've heard a lot about the growth in list prices. All right, so this is looking at the growth in list prices of insulin over the last 4 or 5 years. And the list prices are the top ones. So it's been a fairly rapid increase in list prices. The only people that pay anything based on list prices are Medicare patients. They pay their 25% coinsurance based on the list price of a drug. So it's been painful for Medicare patients. But the way this game works is much more complicated. And the Congress is finally understanding sort of the role that PBM and the middlemen play in this system. The incentives go is that if I increase my list prices, I can get bigger rebates to CVS and other PBMs. And if I give them a bigger rebate, my drug's going to get put on a low tier in a formulary, so that my drug's going to be more widely used. So if I keep increasing my list prices, I give you bigger dollar rebates, it's going to go into, I'm going to get on a tier 1 or tier 2 formulary, and my competitors aren't. So the economics are pretty clear here. And what's kind of fascinating to me on this issue is that those are the list prices. Where does the money go? The bottom line here, that's what's the net price that's been received by the drug companies, the manufacturers. So there's been a big increase in list prices. What manufacturers are getting are declining. So you're wondering, well, wow, that's interesting. Where does that all go? And this is showing over this time period where the money goes. So if you look at 2014, for every $100 net expenditure on insulin, the manufacturers got about 70. The PBMs got about 6. The wholesaler, those are the ones that are selling the drugs to the pharmacy, got about 14. And the health plans were sharing some of this too, along with the pharmacy, who got about 6. Well, let's go 4 years later. So the share that the manufacturer gets of the same $100 is about 46%. The share that went to the pharmacy, because of the way the system works, about 20%. And the PBM went from 5 to 14%, almost tripled. So again, the politics of this are easy. You can go ahead and bedevil the pharmaceutical industry for the high drug prices. But the reality is that what underlines that is the structure of the middlemen that are bottling up most of the money in the system. Now, many Medicaid programs, we're going to see in a minute, have pretty much eliminated this PBM-type structure that you see in the private sector and in Medicare. So that any rebate that is negotiated goes right to the patient at the pharmacy counter. And Ohio just did this a little bit ago, and they found that across the board, not just for 10 drugs, but across the board, what they spent on drugs fell by over 10%, just because they got rid of these rebates that go to the PBMs. They're basically paying the PBMs a per member per month service fee, but you're sort of eliminating all of this middle aspects of revenue. So that'll be on the that will be on the agenda next year. It already is. Talk a little bit about quality. And I mentioned a little bit already on the personnel shortages. That's one of the areas of help that I think telemedicine and RPM can play because it's much less staffing intensive. But if you look at just on the physician side, over just between 2021 and 2022, 70,000 physicians left the workforce. We're expected to see about 30,000 joining this year. And we're seeing similar challenges in other types of healthcare services and healthcare professions as well. So just the shortages are a concern across the board. Second is what's going on in the structure of that physician industry. Well, it's completely different than it was in the Marcus Welby days and 20, even 15 years ago. The physicians are now largely employed, and the largest employer of physicians are health insurance plans. So Optum alone added 20,000 physicians in 2023. They now have just under 100,000 employed physicians or affiliated physicians and 40,000 advanced practice clinicians. So that whole structure of the physician and healthcare provider industry is changed quite dramatically. Third that we see growing out of COVID on the quality side is that we have a really increasing and growing demand for mental and behavioral health services. It's one of the things that you look at telemedicine and ask what services were the highest provided services in telemedicine. It was behavioral health, by far. And it has to do with the dramatic increases that we're seeing in depression, anxiety disorders, suicides. These are all hitting record highs coming out of COVID. So having the approach of working with these patients in a staffing shortage time is going to be a real quality challenge for sure. It seems that we're going to have to, and for better or for worse, and people have different opinions about this, rely on primary care from non-traditional providers. CVS, Amazon, who has One Medical here in town, Walgreens, Walmart pulled out. They didn't see it as a viable economic investment. But increasingly, you're seeing a lot of primary care being delivered in non-traditional places. I think the clinical challenge of that is that those medical records and encounter data sit at the CVS Health Hub. Now, they may share it with Aetna, but they don't share it with my primary care physician at Emory because there's not an interaction between those medical records. There's no interoperability that goes on between these more isolated primary care providers and the broader picture of the patient. So that's a challenge that we have to figure out. How do we sort of populate that patient encounter into a patient record so that the primary physician treating the patient can actually see what's going on. Finally, end up with the uninsured. Certainly, the Affordable Care Act had a major impact on reducing the number of uninsured. But there's a lot left to be done. There are, as we'll talk about in a second, policy options that we can do to build on the ACA. I understand the politics around it. There are some people who like it, don't like it. The bottom line is it is the mechanism we have in place. It is going to be the major way moving forward of how we expand coverage for better, for worse. But it wasn't just all private insurance coverage. What the federal government did was gave the states an offer that said for the first couple of years for Medicaid expansion, largely for single adults and childless couples, we'll pay 100% of the cost. And from years 3 on, we'll pay 90% of the cost. And if you think about states like Georgia or North Carolina, states that have a lot of rural hospitals, where that hospital is the biggest employer in the community, expanding Medicaid coverage and reducing the number of uninsured has a big financial positive impact on those facilities. But unfortunately, the southern states, I think largely for the politics of it, including Georgia, didn't do the expansion. So you still have a lot of those small community-based hospitals, which many of them are closing across the country just because they don't have the revenue to keep their doors open. If you look at our opportunities to move ahead on the uninsured, right now, of those uninsured, 60% of them would be potentially eligible for Medicaid if the states expanded it. And included in that 60% are people that are eligible for the refundable tax credits, the financial help to buy health insurance through the insurance exchanges, as well, but haven't bought them. They're eligible for a subsidy, they haven't bought the insurance, and so on. So that's 60% of the current uninsured that really under the current rubric of the Affordable Care Act, we could pull into the system somehow if we just keep working on it. But to give you a sense of the impact that this has had, the health insurance exchanges and the subsidies came in 2014. So if you look at the reduction between 2012 2013, 2014, there's been a fairly substantial reduction in the number of uninsured, but as I noted, we still have 25 million people who don't have health insurance. So a big impact, for sure. There's a lot more to do, and again, depending on the election, certainly a Harris-Walz administration has talked a lot about building on the ACA, improving it, and so on. That's going to largely depend on the composition of the Congress, which is up in the air. We just don't know how that's going to turn out. But certainly there's the opportunity there to go forward and continue to push these number of uninsured down. We know the clinical importance of having health insurance. We know the impact particularly on people with chronic health care conditions that don't have health insurance. They're not good. It's just poor quality care with poor health care outcomes. So this is just a diagram of the percents, just showing the potential impact that just continue to build on something like the Affordable Care Act could potentially have. So that's a quick overview of the issues. I wanted to leave a lot of time for questions to see if you wanted to go someplace where I didn't go or I didn't add enough color and flavor to what you'd like to hear more about. But again, go ahead and open for questions. And you can see my skills with PowerPoint are quite limited. So.
Thank you so much, Dr. Thorpe, for that informative lecture. We're going to now open the floor for questions. When you have a question, please raise your hand, and one of the faculty members will come up to you. Please, let's try to keep the questions around Dr. Thorpe's presentation, and if we can, one question per person at that moment. All right.
This is rather earlier in the presentation when you were talking about the decrease in funding for research and development as a result of the cap on insulin. This may be just a more political side question, but why not apply the $290 billion in savings for Medicare to research and development for new medication?
Well, that is a pure political question. But I can give you a shot at answering it. So, again, most of the savings comes from the negotiated reductions in drug prices over the next decade. So that's where the bulk of the nearly $50 billion come. The reasons that the White House was so excited about the $250 billion in savings because they used that to pay for a lot of their climate initiatives. So those were used as pay-fors to provide tax credits for carbon emission reductions and spending on other types of infrastructure developments, but really for their climate initiative. So that's where the money went. In terms of the environment for investment, this is sort of a little in the weeds, but I think it's important to point out. What the Inflation Reduction Act did is that for a new drug that comes on the market, they gave them a time period where you weren't subject to negotiations. Could be an expensive drug, but they gave you a time period that no negotiations can happen within this window. Well, they did it differently for small molecule drugs, pills, they're administered at home, and biologics, which are administered in a hospital or by a physician, largely through an injection. They gave a 9-year exclusion to the small molecule drugs, 12 for the biologics. So if you look at where the investment flows are going for venture capital, and even the interest among the pharmaceutical companies, they're increasingly going into biologics. Now, ironically, obviously, biologics are a lot more expensive than small molecule drugs. But that's where the incentives are to invest. The reason that the investment portfolio is tipping away is that it traditionally takes anywhere from 9 to 13 years for a drug to recoup revenue that pays for the R&D. So if you're going to open up small molecule drugs at 9 years, you're cutting a big hole into that ROI calculation that goes on for a manufacturer, and it's going to affect the incentives. I mean, I guess the issue to me was, I didn't like the approach necessarily in doing price regulations, but I liked even less the fact that you're tipping the incentive balance from one class of drugs to another class of drugs. Seniors like pills. Seniors who live in rural areas that have transportation limitations don't like traveling to a hospital to get an insulin shot. So it's a real problem, I think, in terms of, particularly for seniors that may be disabled, have limited mobility, limited transportation needs, to actually get access to these drugs, but certainly it's tilted the balance away from small molecule drugs towards the biologics.
Hello, over here to your right.
Okay. Oh, okay, gotcha.
My name's Matthew with the Georgia State Occupational Therapy Doctorate Program. And I was just wondering, when you're talking about moving to value-based care, like what are some of the examples of care with lower clinical significance, and who would be filling that gap?
Well, I'll tell you what, start with the ones that are clinically indicated. This is the one thing that's, in the Medicare program, there's really two programs. There's Medicare Advantage, which is administered by private health plans, and then there's the original fee-for-service Medicare program. Original fee-for-service Medicare program for drugs today has a uniform 25% coinsurance rate. Could be for drugs that have marginal use, marginal clinical use, and so on. Medicare Advantage, what CMS allowed the plans to do was for the top 6 or 8 categories of chronic diseases, diabetes, CHF, previous stroke, mood disorders, they allowed them to eliminate the cost sharing. And what they found out was that by eliminating the cost sharing, adherence rates went up, and the plan's spending did not go up. Their costs didn't go up because you had offsets in terms of hospital care and so on. In terms of, marginal clinical use, there's a really good website at the University of Michigan. It's called the Value-Based Insurance Design website, and they have sort of a list of things that have limited clinical value that you wouldn't want to encourage patients to do, but then you have the same list, like I just went through, of medications, for example, that have high clinical value that you really want to encourage patients to do. So it's really recognizing the fact that the original Medicare benefit design and most private insurance today was really built on the Blue Cross models of the 1960s. Well, those patients are completely different than we see today. Today's all chronically ill patients with multiple chronic conditions. Back then, they were largely patients that had acute episodes of care, might have died of a heart attack or something, but chronic disease was quite limited. So, we really haven't kept up with the changing demographics of patients. I'll give you one more example of this. The science on treating patients with medications is changing very quickly. So, again, if you look at benefit design, where you may want to start a patient on drug A, and then you wait for them to fail, you move them to drug B, so that's the old design. step therapy design prior authorization, which basically implicitly is saying that all patients are the same. So a patient that needs a medication, really not making a distinguishing factor between the genetics of the patients, race, ethnicity of the patients, perhaps the age of the patients, but where the science is going in pharmacoeconomics is that we're doing an increasingly great job of really understanding how different patients respond to different medications. So that's another one where if we just would allow the science to somehow filter in and let the health insurance benefit design get out of the way some, that would be a way that we could really do a much better job of providing better care at lower cost.
Hi, my name is Octavio. I'm with the physical therapy department, and this is relating to the uninsured question or topic. So how would increasing the coverage of CMS or federally funded programs like Medicare or Medicaid would affect reimbursement rate for providers, and then how would that affect the drive towards concierge or cash-based medicine?
Well, as you know, if you look at, let's take hospitals. You know, on average at hospital, and there's a lot of variation in this, I understand, but a hospital's losing money at Medicaid. So they're generally paying under cost. They're roughly breaking even on Medicare. Some are doing better, some are doing worse. Where you make your money is on the privately insured patients. You can make profit margins of 30, 40%. So to the extent that and the uninsured, put them in the equation too, the uninsured may pay 5 to 10% of the underlying cost of their care, if that. So if you start changing the number of people in each of those categories, the profitability of the providers is going to go up. Fewer uninsured, more Medicaid. Well, you're still losing money in Medicaid, but I may be getting 80% of the cost, not 5%. So that's a win. If you cut Medicare reimbursement, and the places that are going to really take a big hit are these small, rural, community-based hospitals, that's who they largely treat. They treat seniors, they treat low-income patients, and they treat uninsured patients. And they may have some privately insured, depending on the industries in the town, but it could have some real negative impacts on healthcare providers in the market that rely heavily on Medicare and Medicaid to provide healthcare services.
The presidential election is a month away, so if you could look into your crystal ball, I mean, what's going to happen with the Democratic ticket if they win, and what's going to happen with the Republicans?
Well, I guess the best thing I can say is, can we have the election tomorrow? Waiting a whole month is tough. Well, so there's three moving parts. Does the House go Democratic? There's a decent chance of that. Does the Senate flip to be Republican? There's a real decent chance of that too. There's a number of moderate Democratic senators that are either retiring or in really tough situations. So West Virginia, Montana are two good examples of that. But I think if the Democrats win the White House and they have a decent balance in the House and Senate, you will see, as I mentioned, I think you'll see PBM reform. That's one that's got some bipartisan interest. That will be a real politically entertaining thing to watch, because that's going to be, the lobbying money that's going to flow in on that's going to be quite substantial. I do think that they'll build on extending and increasing the subsidies for the Affordable Care Act. I would hope that through the Republican Governors Association that they keep working with the governors on highlighting the fact that this is really not a political issue. This is an economic issue. This is a community development issue for hospitals in rural areas, to keep them open and keep those workers going forward. So I think that that's going to be their focus. I think what I've heard from only The only thing I've heard from J.D. Vance and Trump, take a step back. I don't think there is this stomach on the Republican side to go back after this ACA repeal. I think that they've moved beyond that. I don't think you're going to get a lot of voices that want to go back and revisit that, particularly since there isn't an alternative plan in place, for sure. So I don't think that they'll go there. The only sort of, I think, semi-disturbing proposal I've heard is from Congress, or from Senator Vance, which deals with the underlying fundamentals of insurance. Insurance is designed so that good risks subsidize bad risks, right? That's the whole idea. You're doing risk pooling. And before the ACA, insurance plans were able to deny people with pre-existing conditions coverage. And that was quite a long list of what was deniable. So if we're not going to go back to that, what they're proposing is to separate the risk pools, to take the good risks out and put them in one pool, and take the bad risks out and put them in another pool. Now let's think about what that does to health insurance premiums in those two pools. Certainly, if you're just isolating the bad risk pool, those premiums are going to be really high. If you have the good pool, then premiums are going to be really low. And the estimates are, if something like that happens, you could easily increase the number of uninsured by about 10 million people because of people in that high risk pool facing dramatic increases in premiums. But in terms of big ideas, healthcare, at least on the Republican side, on the presidential side, hasn't been very widely talked about. But they're certainly put their targets in the Congress on these pharmacy benefit managers to reform that industry very substantially. So that's going to be an interesting one to watch. It's going to be a hard one for the public to keep track of because it's by design so complicated. They want it that way. I mean, it's so complicated of an issue in terms of understanding how this whole process works and what they're trying to reform and how the senators are going to explain it to their constituents, that it's going to be challenging. But they started gearing up for it this year, and they'll be back on that next year. And as I mentioned, that's an area that really does have, along with telemedicine, I think, wide bipartisan support.
Dr. Thorpe,
Now, this isn't going to be a trick question, is it?
of course not. I'm Rodney Lynn, Dean of the School of Public Health. Thanks for your remarks. I have just two quick questions for you. You started your talk really talking about the burden of chronic disease on the system. The system is really burdened by chronic disease, and that's driving much of the cost. You pointed to obesity, and I suppose my question is, you didn't talk much about obesity. Has that battle been lost, or are new medications like GLP-1s turning the tide? Where do we stand on that battle around obesity? Because that's as you put it, really the driver of the chronic disease that we're seeing that is burdening the system. So that was one question. And the second quick question is around, it's a policy question around balancing sort of regulation on like medication. You talked about insulin, capping insulin, but then you said, well, this is a negative because innovation is stifled. So do we have the balance right in terms of regulating those medications so that they're widely available? Will they continue to be available if they're regulated in this way and there's no real incentive for private industry to keep producing these medications?
No, both good questions. Have we lost the battle on obesity? No. It's kind of slowed coming out of COVID a little bit in terms of the prevalence, but the trends are still disturbing. That's what I mentioned the GLP-1 drugs because I think they're going to be a real centerpiece of a strategy going forward. And when you combine the GLP drugs with diet, exercise, nutrition, lifestyle changes to really drive those long-term changes in health status, what we're seeing is the reduction in healthcare spending is substantial. So if you do a table, which we just finished up one, that looks at baseline BMI, starting at 30, going to 45, and then look at reductions in spending, 5, 10, 15, 20, 25, particularly for the, and this is the area where you have the biggest growth in obesity numbers, is the people 40 and above. The savings in spending in that population could be 25, 30%. At least. We're seeing in the randomized trials numbers that are showing, averages of 15%, but then we're also seeing a third of the people losing almost 30% of their body weight. So the real policy challenge here will be on the pricing side. And what you're starting to see is two things happen. One is that part of the pricing side is due to the fact that they were overwhelmed by demand. That the supply just wasn't there. I mean, really, in the early days, Novo had a factory in Ireland that was developing Ozempic. So they're rapidly increasing manufacturing capacity. So that is going to help. I think to the extent that you get more and more of these competitors coming out, Eli Lilly, Amgen's looking at it, in addition to Novo, that's going to have an impact on pricing as well. But, to date, and this is our focus, unfortunately, traditionally, is that we look at the initial big upfront costs. You do a drug, we know what it costs. But we have a shortism, the mentality that we don't look at the discounted benefits to the patient and really look at what we're buying with that. And one of the good examples of that was the Hep C medications. Sure, they're expensive, but they had a 99% effectiveness rate. If I was running a prison system, I would give them out free because it's effective and it reduces retransmission. But we don't really think about sort of the discounted benefit side of this. And so I talked so much in the first one. The second question was on. Yeah, so on that one, I would have gone, and again, it goes to who the client here is that you're trying to help. To me, in the drug legislation, I would have done two things. Main focus would have been on patients. And that was not a big coster. But capping the patients out of pocket, I think is important. Because I think you'd see in the research we see from the Medicare Advantage plans that if people are more adherent, that you're really not increasing overall spending because you have a cut in hospitalizations and so on. I would have done the PBM piece because you could have gotten all the benefits in reducing underlying risk drug prices across the board, not just for the top 10 and the top 25, but across the board if you reform the PBM industry and pull that money out of the middle, largely that I showed. It has the two advantages of it would have reduced drug prices, and it would have not had these bad incentives on innovation and investment. So I just think that, unfortunately, the politics of it worked out that it's really easy to go after these drug companies. It's very politically appealing, I get it. Polls well. But it really didn't deal with the underlying problem that we should have solved, I think first, which is this restructuring of the pharmaceutical benefit management industry.
All right, so that was our last question tonight. Again, thank you, Dr. Thorpe.
Thank you.
That was very, very fascinating, pulling back the veil just a little bit, right? Okay, can we give our speaker one more round of applause? Before we leave, I have a couple of additional recognitions. I want to say thank you to our Faculty Advisory Committee who organizes the selection of tonight's speaker, and to our student ambassadors who helped us staff this event for tonight. Thank you again for joining us. Thank you for coming, staying, asking such brilliant questions, and we look forward to seeing you next year. Good night.
Respiratory therapy, I'll be at the front.